Omar, glad you're here. So we have two of our subject matter expert groups represented so far, and lovely to have you all. Anyone, if we have another minute to go, looks like we're trickling in. Again, Sarah DeSilvi, glad you all are here. This is our March 19th Terminology Public Call. All right. We try to start at 4:03 on the dot, and I'm going to start. Again, welcome everybody. I think I've introduced myself, but I'm Sarah DeSilvi. Welcome to the Child Maltreatment, Mistreatment of Non-Elder Vulnerable Adults, and Legal Needs Concepts cycle of our Terminology Public Meetings. Next slide. We do welcome you all. Everyone's muted upon entry, but we have a lot of conversation as we go forward. Calls are recorded, and recordings are always available on the Gravity Confluence after the call. We do really encourage active participation. In fact, we rely upon it for our consensus process. So if you use the Zoom chat, send things to everybody or raise your hand, and we'll try to make sure that we work through the content in consensus fashion today. Next slide. We are, as part of HL7, an ANSI accredited entity, which means the American National Standards Institute. So we are required as such to follow antitrust practices. So we ask that not just ourselves, but all attendees speaking or providing written communication shall refrain from any discussion which may provide the basis for an inference that they have agreed to or take any action related to prices, services, production, and allocation of markets, or any other matter having a market effect. Participants shall not discuss their pricing or others' pricing or any terms that might affect pricing or fees, such as costs, discounts, terms of sales, or profit margins. Adherence to these guidelines involves not only avoidance of antitrust violations, but avoidance of behavior that might be construed as such. Thank you so much. Next slide. Brief announcements today, and then we'll be going through our three domains of reference and updates. We're at that kind of inflection point where we have some stable, some emerging stability in definitions and instruments, and are working rapidly to try to fill in our goal and intervention concepts at this stage of development. We have some new domain enhancements, updates. We're going to have a friend of Gravity come back and present on one of them. And then we'll close with homework and next steps. Next slide. Next slide. I know the highest level update again on USCDI v7. We have gotten some member comments on this as well, but comments on draft USCDI v7 are due by April 13th. So we're just trying to make sure that everyone's aware of that. They affect Gravity's submissions in V2 for problem, patient goal, and procedure because they move specific call-in for SDOH on those things into examples. Again, so we just want to make sure that all are aware. We're facilitating comments through our membership and through HL7 that we'll be submitting collectively. But we encourage anybody who cares at all to submit comments externally as well. Next slide. Very focused updates here. We just had a huge conference push. Many of you were at HIMSS. We had a huge representation of members presenting at HIMSS. I think there were like 6 different presentations at least, which is pretty exciting. So just high-level workstream updates. Technical workstream is still working through ballot reconciliation. We just had a meeting, and we'll have another one in a couple weeks. And we always post the tickets that we're working on in advance. I think we have like 11 left. Even though that doesn't mean we're through, because there's a lot of work to do to account for the adjudication of ballots in ST 3.0 toward the final publishing of it later this year. And implementation, we're kick off next week. We're super excited. We have a very lean, mean implementation work stream for 2026. And so we have topics every other odd months at the last Thursday of the month, 2 to 3 p.m. Eastern Standard Time, because we're really trying to not conflict with other HL7 meetings. And we're collecting information in advance through a survey, and then going to talk about findings and answers to specific problems each meeting. The first topic of the year is state implementations of gravity standards and rural health transformation. And then the next meeting is slated to be on pathways for identifying positive screenings after utilizing standardized instruments. Lucy?
Sarah, do you have a sense of response to your survey yet?
Yeah, we're getting good responses across the spectrum, right? So we have some stakeholders types that we identified in the first question, but now we're getting, yeah, it's great. We just did another final push. And we have, some stakeholders that we weren't specifically querying, they're responding as well. It's going quite well.
Thanks.
Yeah. Yeah. We did, just yesterday, Demry, so it's implementation's a partnership with Civitas, as you know. Demry sent out another listserv push through Gravity, HubSpots, and then she's also doing the same through Civitas. And I posted something on LinkedIn. So we're like really trying to make sure that we have a robust response, and we're doing great so far. All right, next slide. Any questions beyond Lucy's ever astute question? Okay, next slide. What is Gravity? I think we can probably streamline this for the team we have here. So we're a collaborative with a goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. Next slide. Incredibly grateful for our membership, right? Again, we are governed by our membership, and we have both sponsoring members and designated members that help make the work go around. Next slide. And here we are, we have this meeting and next meeting, which are our last kind of brainstorming meeting. That's why I was talking about the inflection point. So you're going to see a lot of new concepts over a lot of new concepts this meeting, and then a host of new concepts by the next meeting as we solidify concepts across each of our 4 activities: standardized instruments, diagnoses, goals, and interventions. If you have anything you feel like needs to be present, please send it to gravityproject@hl7.org. We go into formal end-to-end review in the middle of April, and that's a time there's some new stuff happening, but it's mostly just assessing and trying to make sure the whole collective set is where we aim to be. Next slide. And then master lists are coming. So Sarah Bahal ever so wisely put this back here. You can see the social risk domain build section of the Confluence all the way at the bottom of our 3 domains of reference this cycle. And they're posted on Tuesdays at 5 p.m. after the public call. So you're going to start to see that these masters are posted on Tuesday, which gives us time to align them with the findings of the meeting. And then we'll be versioning those masters toward the consensus vote in May. Next slide. Any questions? All right, keeping it going. Next slide. All right, so this is the mistreatment of non-elder vulnerable adults concepts. We have one of our amazing subject matter experts with us today, and we have a few updates. And so I'm going to present some content, lean on SMEs to answer questions if they're able, and then Asha is going to take on the instruments as she does. Next slide. So our amazing subject matter experts, Dr. Jeffrey Hall, Dr. Rana Cierno, and Dr. Shannon Griffin-Blake. I'm incredibly grateful for them. Next slide. And just this has been stated before, but just letting everybody know the mission is to address abuse of non-elder adults that triggers engagement in adult protective services. That required us to develop a definition of vulnerability. We are talking about the method of establishing vulnerability and the risks and benefits of doing so. And you're going to be seeing that vulnerability definition blooming over the course of the next slides. And this last bullet's important, that our SMEs are ever so careful, as we've mentioned over the last few meetings, to understand that vulnerability is contextual. And one of the lenses with the vulnerabilities to be considered is in the type of mistreatment. So there's this lens of matching the type of vulnerability to the type of mistreatment that the person is experiencing. Next slide. All right, this is a long definition. Again, this is a category definition, and the reason why I'm stating it as such is that this is the definition for the overarching work that we do. And you can see the same thing in child mistreatment, because we're going to have this category of the work, and then we're going to have the actual diagnoses and condition concepts that we're creating. So our working category definition, like what is mistreatment of non-elder vulnerable adults, is as follows. And you can see the hash mark because in our alignment with, I think we mentioned this last time, in our alignment with international references, our perspective on whether mistreatment or maltreatment is appropriate is kind of in flux. So we have this hash mark here. Mistreatment or maltreatment of non-elder vulnerable adults refers to all forms of physical and or emotional ill treatment, sexual abuse, neglect or negligent treatment, or commercial or other exploitation that result in actual or potential harm to an adult whose vulnerability may increase the risk, severity, or duration of such harm. There's lots of sub-definitions that might emerge in there. The amazing Jeff Hall is on the call today, was talking about all the other things that need to be defined in that, but that's at the highest level. And then vulnerability is a state of physical, emotional, cognitive, or other impairment that increases an individual's risk of experiencing abuse, neglect, exploitation, or violence, and increases the severity or duration of its consequences by making the person unable to independently meet their basic needs, seek help or report mistreatment, maltreatment, protect themselves from harm, or access individuals or social support systems willing and able to provide adequate protection. So in that, you can see the bullets that we had in the previous slide, right? The concept of vulnerability, its relation to the type of maltreatment, and how that risk-benefit analysis of when it feels appropriate to override an individual's autonomy because of their vulnerability in order to help them. Jeffrey, since you're on, anything you want to say further wise, Jeff Hall, on this definition, given our I hate to call you in, but I always do. Anything further there? Are you good?
No, I think I previously mentioned that some of what we added where vulnerability is concerned also tries to provide a little bit of flexibility where the variation across states is
Mhm.
concerned in terms of what tends to be covered in some of the statute definitions.
That,
So if you take a look at that part at the tail end of the vulnerability definition, beginning with by, there are experiences captured there that are intentionally intended to connect to some of the things that are mentioned in some of the different state statutes. So just wanted to provide a little bit of context around that part of things.
Thank you for reminding us of that. And it's really important from where we started, right? Which was kind of perhaps too closely bound before you all came to light. We had to kick off without our SMEs meeting, without meeting with our SMEs first. So thank you for that perspective. Jeff is a pleasure to work with, by the way. All right, so on to the next slide. And then we're going to go before we, and Jeff, this is again what we were talking about with you and Shannon and Ron. We wanted to just kind of like level set in some of the considerations of using standardized instruments and doing screening. And these are some things we're finding, and you're going to see that in the following slides. So themes regarding instruments in this domain. There are few instruments that are validated specifically for this purpose. There are intimate partner violence instruments, which cover a fraction of it. There are elder abuse instruments, which cover similar like phenomena, but not the specific population. And there are general interpersonal safety instruments, but there's not a lot of instruments that cover this specific domain. And there also is an observation that some instruments are, out of date or not as adequately reflecting up-to-date understanding of the phenomenon and how to measure it, right? And we see this in things like the types of language that we know elicits correct, more sensitive and specific responses, right? We've learned a lot about measuring maltreatment and mistreatment over the years, and especially regarding things like sexuality and sexual abuse. The more explicit you are, the more sensitive your instrument is. So that's something that we've seen as well. We also know the general desire, and we recovered this with an intimate partner violence as well, to level set prior to employing instruments, and that remains critical. We think about the CUES model, we've been talking about that, but I want to note that our amazing SMEs think about how to adapt that kind of level setting given some of the disabilities and cognitive impairments that may be present in individuals with vulnerability, right? Not even the level setting isn't adapted to be fully accessible to the individuals we're trying to support. Basically, and there's a lot, like, please develop better instruments ecosystem or more instruments, so this need can be addressed. Anything further to say on that topic, friends? I think we just say this because we're about to go into the one instrument that is fit for purpose for a specific population, even with some caveats on how it could be updated. Okay, next slide. Asha, take it away.
All right. Good afternoon, everyone. I'm excited to go over the screening instruments that we have so far in our domains. And the first one is the mistreatment of non-elder vulnerable adults abuse assessment screen disability, the AAS/D. And this is a 4-item screener with 4 questions with a yes or no. And if yes, then circle who, because there are multiple perpetrators that can be identified here. And the first question, I won't go into reading all of these because we have reviewed them again last time. This is an abuse assessment screen for those who are disabled with 4 different question categories. And as Sarah has just said, our SMEs accepted this for right now to include it in the domain, but they are noting that there are some limitations with this particular screener. So perhaps more to come, and maybe not, because there is a gap in screening methodologies that are tailored specifically for this population. Lucy, go ahead.
Ashley, who is the source of this one?
Oh,
Where does it come from?
that's a good question.
That's a great question. And I don't know off the top of my head, I can't remember, but there is a link on the slide where you can go and check and find out the source of this particular screener.
Yeah, I saw the link and it didn't tell me anything. That's why I raised my hand.
Ah,
Okay.
okay. Well, next time we will bring that to you specifically, Lucy.
Thank you.
Noting it down. You're welcome.
I think especially when we're in a situation where instruments are rare,
Mm-hmm.
one always wants to be able to trust what's available.
Mm-hmm.
Sure.
And the source is an element in establishing trust.
Understood.
Yes, and I think Sarah just gave us the link, so I have the citation. I can put that there. One thing I want to note, though, is that, and I think I don't know if I heard you say this. So this is an instrument from 2001, correct, Asha? Like it's
Yes.
yeah,
It's about 20 years old.
yeah. And did you mention the sexual activities? The question. So it's not just the population; it's the fact that when I was mentioning generally that, like, not necessarily reflecting the up-to-date methods of how we measure things. The sexual activities question is one that our experts called into light because and they went through this with a fine-tooth comb and they agree it's too important to not include. but that's not the way we identify sexual abuse normally in 2026, right? We're explicit about it because like we and saying like such as this, or this, because that elicits a more sensitive response. Just noting that. I mentioned hypothetically that that might have occur, and now I'm mentioning specifically that this is where it is. All right. Anything else? Okay, sounds good. Next slide.
All right.
And then there's a lot of, you're going to see, like I mentioned, this inflection point over the next couple of weeks. There's a lot of goal concepts and intervention concepts we're reviewing. There's a lot we're pulling through from other domains. But again, thank you. We've been working deep. They're really defining something new. And so it's a lot that just coming to the agreement of what we're trying to define has taken some time, and their thoughtfulness is incredibly appreciated. Next slide. All right. Child maltreatment experts. Here we are, the amazing Emily Brown, Dr. Catherine Wells, and Phil Scribano. All child abuse pediatricians. I do not think we have any of them on the call, right? So we're gonna do our best to represent their wisdom in their absence. Next slide. So the general definition of child maltreatment, again, this is the category, and I changed the word here, but not otherwise. Like, what is the category of the things we're covering? Child maltreatment is the abuse and neglect of people under 18 years of age. It includes all forms of physical and emotional ill treatment, sexual abuse, neglect, or negligent treatment, or commercial or other exploitation, resulting in actual or potential harm to the child's health, survival, development, or dignity in the context of a relationship of responsibility, trust, or power. And as we mentioned a couple weeks ago, really leaning into the relationships of responsibility, trust, and power, and how that expands some kind of previous assumptions regarding child maltreatment's been our work of the last month, I'd say. So undoing the idea that it has to be a primary caregiver or a parent, and really thinking more comprehensively about the relationships and the proxies of caregiving children experience as they navigate community, whether it be in school or in places of worship or in clubs or in institutional settings. And that's what our child abuse SMEs have been deep diving us in over the last month. Lucy?
I'm going to get really tiresome here. The last line, in the context of a relationship of, when I think about children, I immediately think of dependency. Is that implicit here in responsibility, trust, or power? Was that rejected for some reason, or is that so self-evident we don't even talk about it?
Well, that actually puts us back in the idea of the primary caregiver relationship. And that's what I was saying we're trying to liberate ourselves from, because I wouldn't say like a teacher is a dependent really I mean, again, no SMEs are here at this time. I do not want to answer for them. But
I would say, Sarah, this is or responsibility, trust, or power. So responsibility or trust or power.
correct.
So dependency or responsibility, or it ends, because the primary caregiver,
What would
well,
be
I
what
have
would be the
no idea
benefit
I'm
of
sorry.
what would be the benefit of adding dependency into this
Well,
definition?
to me, it would evoke the parents or whoever's taking care of this person, not necessarily the universe of people that they interact with.
Yes, and I think that's what I'm trying to say is we're trying to make sure it represents the universe of people they interact with who have power relationships with them, not just their parents.
But
Right.
it doesn't, to me, okay. The
No, I
parents
hear
to
you.
me are the first line of abuse and neglect. That's to me, as a complete non-SME here, that's where I first identify abuse and neglect, because that's what I encounter, that's what I read about, that's what I've
Yeah.
learned, and so forth. So it's not clear to me why it's not being referenced. Even though, of course, you want to expand the universe. So you say dependency or responsibility, and so you
So
get
we'll
to the
noodle.
teachers and the doctors and whoever.
Yeah, so we'll noodle on that. Again, this is a WHO
Okay.
definition, so we can't change it too much. but I think it's actually in there, the concept, like that's what we're, I think what you're, I think it's kind oh, Omar's raising his hand. But I think it's in there, but I hear you. But I hear you. Omar,
Thank you.
do you
I
want
was
to?
actually just reflecting on it. I think it may be limited, right? Because what about in the context of not having a relationship of responsibility, trust, or power? Child maltreatment occurs in those contexts too, right? So you see what I'm saying?
Oh,
You may go through child maltreatment in the absence of a relationship of responsibility, trust, or power.
okay, so those, yeah, so it's interesting because on the one, so we started conceptually with the parent and primary caregiver assumption, because that was the assumption in the
Right.
beginning, right? We are expanding with the help of who beyond that to relationships of both primary and secondary caregiver relationships, which means like proxy
Right.
responsibility, right? And that's what WHO and CDC go into very deeply, these relationships of proxy caregiver status. We'll come back. We actually are going to vet with our
I'm
SMEs.
thinking I'm
Yeah.
thinking about the child that goes to the bathroom, right? And a stranger comes out and boom. You see what I'm saying?
I
In
hear
the
you.
context of there's no relationship, right? There's no trust or power engaged there, but then
Yeah.
child maltreatment occurs in those contexts.
Okay, so we will also hold space for that with our SMEs. I think it's interesting. There's a couple themes that are possible in there. Because we've been talking a lot about actually neglect and exploitation too, like protecting children from harm. So anyway, so I have Lucy's anchor in this in ensuring the concept represents this primary relationship, and I have Omar expanding it on the other side to ensure that we're examining when responsibility, trust, or power might not be present. And we will bring those concepts both to the SMEs and come back in 2 weeks. um, no. Well, it depends on what you mean by frequency. Okay, so Lucy, I promise I'm going to bring this back to the SMEs, and I'm sorry they're not here today. But I want to say the expansion from parent and caregiver was primary caregiver was very intentional, based on the experience of our subject matter experts, right? So when they tested this and all the things they wanted to say, they did not feel like binding it in the parent and primary caregiver relationship was sufficient. And so that's what the WHO definition allowed us to level set in. And then in addition, the CDC definitions of maltreatment expand on those two different types of caregiver relationships as well. So I think we're kind of like anchoring in that. We just need to be inclusive of parents too, which I will vet with the SMEs. Cool. Okay. Next slide. All right. But my conceptual, okay, so what you're going to see here, and these are the concepts, and so this is even more fascinating, I think, right? So these are all the different types of definitions for the concepts themselves, right? So child maltreatment is the category. We need to make sure it's representative of all the things that we want to name in this domain. The actual diagnoses and the conditions that we're finding are going to be all different types of subtypes. I hope that makes sense. So physical abuse, we have two different definitions we're working with. They're both from the CDC. The first one's from the CDC webpage on the concept, and the second is in the surveillance definitions document that the CDC creates for child maltreatment, similar to the one we referenced when we did elder abuse in 2021, I think it was. And then there's two different from the same CDC 1 and 2 are consistently labeled throughout, right? So you can see us. So my likely that would be psychological abuse, or it would be exploitation, depending on grooming for what, right? We had some pretty like serious conversations about parental and primary caregiver roles in non-primary caregiver sexual exploitation cases. And certainly grooming within, the violence and control relationships is an aspect of psychological abuse as well. I don't know if anybody else, but that's we all of those types of relationships we basically think about, our SMEs are thinking about things in their expertise that they try to name and making sure it fits into each of these different concepts. And then maybe Sarah B, grooming is a specific, because the CDC surveillance document goes into specific subtypes of all of the under each of these different things, like as exampled by doot 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 doot. So Lucy, maybe it's in there. I can look and then come back. And then Jeff is saying something brilliant, likely. Oh, thank you. Oh, Jeff, so lovely. Thank you so much. He's adding context to the mistreatment of non-elder vulnerable adults domain. So what we're doing now with our SMEs is taking these types of different subtypes of abuse and leveling and looking at these different diagnoses and ensuring they represent the breadth of what our SMEs want to name in the concept. Yes, Lucy?
I mentioned grooming because we all probably are aware of a sensational expose this week about sexual abuse. And the term grooming is the word that the victims are reported to have
Correct.
used with
Correct.
respect to ultimate sexual abuse. So I didn't see the word grooming in here under sexual abuse. So I guess I'm raising for SME comment. Number one, examples include fondling, penetration, and so forth. Examples include grooming, giving rides, giving presents, giving money, giving promises. I mean, all the things that you read about victims saying what happened to them.
It might be, that's what I'm saying. I think it might be contained in exploitation, which is non-contact sexual interaction. Like, I think, I'm wondering, you know what I mean? And we'll get the definition. I hear you. And those are the kinds of things we know happen in exploitation relationships as well. But we will look into it. And then grooming is
I
not
guess
only,
exploitation, just this complete amateur here. When I hear the word exploitation, I immediately think financial.
oh,
But
yes, yeah,
if
no,
exploitation is a term of art with
yeah.
respect to surveying or addressing sexual abuse, then I will certainly learn that. But I think the word grooming now is so current. And okay, that was my thought there. Thanks.
Thank you so much. We'll make sure that the concepts included, that the phenomena are things that we've been covering within discussions on exploitation. And trying to figure out where it goes. Okay. And I'm just going to note the grooming does happen not just within sexual maltreatment types. It's a at least, I mean, that activity of of like prepping the person to receive maltreatment, it happens across different abuse types. Okay. So we're going to work with our SMEs to figure out which of these is salient. We're going to make sure that we vet the examples that you all are raising with them, because that's what we've been doing to date. And then we're going to be settling on a concept definition when we return in a couple weeks. Again, we gather every single one of your examples and bring them back to the SMEs for consideration. And I'm like, if they're not able to be here in the meeting. Okay, next slide. And then these are, again, multiple concepts, multiple definitions. There's actually just one definition for medical child abuse. We've had it up there on the slide for some time, but we haven't had a definition. So medical child abuse is unnecessary and harmful or potentially harmful medical care at the instigation of a caretaker. And this definition came from the American Academy of Pediatrics Committee on Child Abuse and Neglect. And this is our working definition for this concept at this time. When our subject matter experts were thinking about missing types of abuse, this was the salient type that they felt like needed to be named. There are three different concepts in neglect that they feel that they want to elevate as well, and we have two different definition sources. One is the American Academy of Pediatrics, and then one again is the CDC Uniform Definitions for Surveillance document. They are very, very similar, but the CDC ones tend to be a little bit more explicit. And we'll be deciding on which of these two definitions that to be going forward with when we come back. There are other types of neglect that are not on this table. The subject matter experts felt like they didn't rise yet to the level of requirements for clinical documentation, even though we can consider them in future time. These are the three they felt like were most critical to name. And then just noting that the CDC definition for medical neglect is medical/dental neglect, but the AAP just calls it medical neglect. And so we'll be working on that as well. Next slide. And so this is the same thing we've said before, and then Asha's going to come in and present on the instruments. So this is our approach to standardized instruments. Again, not all instruments are intended to be used for screening. Some instruments are only for standardized assessment methods or deeper assessment with person level completion. And we just want to note this because it's relevant when we think about this domain. Next slide. And then Asha, I'm going to let you take this because it's an intro into the instrument slide. Does that sound good?
Sounds good. Sounds good.
Okay, friend.
So this is a slide that we have used for a few weeks now because we wanted to be very clear, or our SMEs wanted to be very clear about guardrails for child maltreatment. And so we offered them, there were three options that they could choose: no standardized instruments, standardized instruments with indication they only should be used for deeper assessment, or standardized instruments used for both screening and assessment with clear guardrails. And that was the route that our subject matter experts decided to take. And so the guardrail themes are these. So they want to use instruments validated in specific settings with those within those settings, and use instruments validated with specific professions, roles, or training within the profession role training. An example is a social worker, psychologist, or a trained registered nurse. So with that, we have two standardized instruments that our SMEs have approved. I will tell you there is a whole host of other tools that are in the pipeline for evaluation. And so at our next meeting, we will have more screening instruments to share with you. The first is the Childhood Trauma Questionnaire short form, and then the Pittsburgh Child Abuse Screening Tool, the PCAST. So we'll talk about the CTQ first. The CTQ has 5 clinical scales: sexual, physical, emotional abuse, physical, and emotional neglect. And it has a 5-point Likert scale. I won't go into all of the subcategory or the subscale questions that are there for time's sake, and because we did review them last week, but you can see that they are there right there. This has been standardized, validated for use in the emergency room and outpatient settings with trained clinicians only, all right? And so that is the context of the CTQ. Moving to the PCAST, again, this is another assessment instrument that has been validated for use in the emergency room, and it's an assessment for child abuse or child maltreatment, rather. There are 5 questions, and it's an assessment. So, we get to question 3, and it is a physical examination with a checkoff. Is this present? Is this present? Is this present? And the answer options are yes and no. Okay.
So Asha, this
Yes.
is kind of interesting because it's not asking about you. It's
Correct.
coming from the clinician.
Yeah,
That's
it's an assessment
yeah.
method, not an assessment questionnaire.
Right, right.
Yeah.
Yes.
Yeah,
Yes.
yeah.
Yes, this is an assessment method that a trained clinician would use. to assess child maltreatment.
And
Thanks,
Susan,
Susan.
this relates to all the work you're doing with nursing standards of documentation, right? So this,
Mhm.
luckily,
Yeah,
Susan,
yeah, yeah.
she's like, oh yeah, I'm all over this. These are nurses in emergency room settings with training, completing this formal assessment, which then generates like a reasonable observation, Susan. Yes.
That's it. All right. And then, Sarah, I will turn it over to you. If there are no questions about those two tools, and there probably is not because we have presented them before, to talk about the goals.
And I just want to note that Lucy is elevating types of neglect that we did not include in our top few. And so we'll just take them back to the SMEs and see. Like educational neglect was one of the types of neglect, and the SMEs in their extensive experience felt like that didn't need a term at this time, but we will present that to the SMEs and see. It exists. So we are working on goals with our subject matter experts. It's both specific to maltreatment and then broad goals related to both child and caregiver well-being and thriving. More to come. There's so many that we didn't want to present them now. And so we're gonna be like coaxing them to some clarity. And like next meeting should be a host of materials. Next meeting, we can also expect that instruments that we've already presented will be found on the Confluence as they usually are as we focus on new materials, just bracing you all because we do have a lot to get through every meeting. So when things have been thoroughly presented, we kind of just say, look here or look on the master. All right, next slide. This is our intervention approach, and I'm going to say this slide so that we don't spend time naming every single specialty on the ensuing slides because there's a lot. And you can look it on the master and you can see them all. I'm going to save myself some words here. So general themes, and you can imagine why, are topics in educating about mandated reporting. And this is the requirement of clinicians and certain professionals to notify Child Protective Services and law enforcement about the presence of abuse when it's present, right? This is firmly rooted in developmental and contextual like moments. Like sometimes it's not safe to the patient to educate about mandated reporting, but sometimes it is. Sometimes the patient's not old enough to understand, and sometimes they are, right? So AAP, pediatricians are always contextually and developmentally aligned. Other intervention themes is you can see community entities that clinicians refer to in the role of mandated reporting. So whether this be law enforcement or child protective services, just as we referred to adult protective services and elder abuse, this is child protective services and then law enforcement. And we're trying to, figure out risk benefit analysis of law enforcement, knowing that we don't refer to these entities. We're talking about educating about connecting to them, right? The next thing that we're talking about are specialties that are critical for helping the child heal after a maltreatment event. And this is physically heal and emotionally heal, right? So the actual clinicians that repair physical damage to the body, that help in therapeutic ways to help the patient, the child return to optimal functioning, and then mental and behavioral health strategies, including things like play therapy. We also are including specialists like Child Life that help kids cope with invasive procedures and scary things after scary things have happened, right? So all of that helping the kid heal after the maltreatment event, those specialties are included. And then lastly, resources that support families in collective healing, like healing the parent or caregiver, even if they're the perpetrator or not the perpetrator, right? In strengthening families and supporting families and meeting families where they are, right? So those are the themes for our interventions, and there's a lot of blooming over the course of the last week. And I'm just going to go to the next slides and we can name them. We're not going to talk about all of them, but they'll see them on the master, comment them like in comments because there's really too many to name here. But you can see this education concept, mandated reporting, home visitation. You can see financial interventions there, parenting programs, family support programs, physical therapy, OT, speech therapy, urology, plastic surgery. Next slide. neurology, and all these host of other specialties, right? So our SMEs, as experts who are called in the presence of abuse, just went down the list of all the specialties that would be needed for repair and treatment. Like, special immunology in the place of like HIV exposure or infectious disease for other disease types. And then we'll be refining these definitions as we go forward. And just note, the definitions of these specialties do relate to some of the concepts we've defined over in the classification of social and medical services work. So we'll be aligning our definitions across those two efforts. Whew. Next slide. Okay, the best place to interact with that massive list is in the master when it's posted on Tuesday. And then please let us know if you see gaps and opportunities. We really want to get a full list. And there's a whole bunch of more concepts that will be coming back onto in 2 meetings time as well. Next slide. Legal needs. Omar. Omar's here. Next slide. All right, our amazing subject matter experts are Jeremy Spiegel, Dr. Marsha Regenstein, Omar Martinez, and Teresa Brabson. Grateful for them. Next slide. And then this is gonna, legal needs is, the definition of legal needs is the category, unlike the maltreatment concepts. The concept we're working on doesn't need a category because it's the same thing as the problem statement. So that's why there's no categorical definition. And Asha, I'm going to let you talk about this and all the instruments. Go team.
All right. So the assessment of our current and risk of future legal needs. What we have clarified, the legal needs screener versus the SDOH screener, right? Instruments must contain a connection to legal needs in order to really be valid in this domain. And instruments can include SDOH related questions if there's an aspect that connects the obtaining legal help, right? It has to connect to obtaining legal help. Inclusion of instruments that have a history or / potential of false positives, as there is still a value of including those screeners. And there's a capacity to help and the right person to help. So these are the explorations that we have been going through as we've been debating screening assessments for legal needs. One thing just to note, the Legal Services Corporation, which funds many legal needs MLP clinics, will not fund MLPs to do 2 things, and that's immigration services and criminal legal services. There are some MLPs that do not accept LSC funding, like the Camden Coalition, and in that case, they do service immigration and criminal legal issues. So that's one consideration we wanted to lift up as we talk about really developing the concepts for this domain. Moving on to the standardized instruments. So as we noted last time, we have 2 screening instruments. So this domain is somewhat stable. If you have others, please send them. We have a version of the iHelp, and iHelp stands for income insurance, housing and utilities, education and employment, legal status, and personal and family stability. Then we have the Organizational Partnership for Healthy Living Resource Guide, short for OPAL. And this comes from a study from 2 of our subject matter experts, Teresa and Omar. But first, we'll talk about the iHelp, this version of the iHelp that came out. Again, it breaks down according to that acronym of income and all those other categories that we just talked about. And so each of the questions can have a different answer option, and you see those listed there. I won't go into all of them for the sake of time. And then the iHelp tool wraps up with these following questions. And again, you see the answer options noted there on the side of the screen. Any questions about the iHelp? All right, then we will keep moving in the interest of time to the OPAL tool. And this is a pretty simple screener. It says, would you like help with? And then it lists all of these domains that an individual may need help with. And so again, this was a tool that was developed by two of our subject matter experts. The cool thing about this study that they did showed it was this tool was used for people with living with HIV, and they were able to demonstrate that access to an MLP improved health outcomes for people living with HIV, and decreased their viral load as a result of having access to MLP services. Susan,
So,
go ahead. Mhm.
yeah, this crosses a lot of our domains, and there's just not very few questions for legal needs.
Oh, sorry, there's a preface. This is that preface. Asha, we keep on forgetting to put the context in there.
We do.
Sorry, Susan, we got you. We got you.
Okay.
This
Yes.
is not do you need there's a contextual heading and our apologies and all of the things that says our team of legal, and actually Omar, this is your baby.
Omar, would you like to say anything
I'm like, here
about
I am,
the
like,
tool?
here I'm speaking to this instrument, and it's Omar's baby, but there is like a heading concept that speaks to that sets the context for what legal help being the driver. He just gave me a thumbs up, so
He
I
said
think
that's good.
yeah, we're good. Susan, yeah, I promise you, I would never do what you worried was about to happen. All right, moving on.
Moving on. Okay, on to diagnosis, Sarah.
All right, here we go. So we have come to some decisions with our amazing subject matter experts, and that is that there was an existing concept of legal problem, but we knew we wanted to name legal needs. And when we examine the literature, they're actually used interchangeably so consistently that we decided to create them as, to imagine them as synonyms. The current concept in terminology in SNOMED CT doesn't have a definition, so that gives us room to lean into defining it. Gravity does that often. So if a SNOMED concept exists, but there's no definition for it, we lean into it. And so we have a definition of legal needs that our SMEs have agreed upon right now that we're going to be leaning into. Legal needs arise when a person has a legal conflict, problem, issue, and or matter for which they would benefit from advocacy, Omar, legal assistance, or justice system intervention, whether or not they are aware of it. Right? And this was, luckily when you're working with like subject matter experts, just like with we're calling it MNEVA because it's so hard to say, mistreatment of non-elder vulnerable adults. They can reference their own literature and revise it to create new definitions. And so we are still exploring health harming legal needs as a concept, and we're still discussing risk benefit of defining legal needs that rise to requiring intervention from a legal professional. And that last bullet, there's a lot in there. So we recognize that it might be helpful to differentiate legal needs that a social worker might be able to solve and legal needs that might require an attorney or non-attorney legal advocate, right? Or like paralegal. We recognize that from the point of referring for assistance, right? A social worker being like, this is beyond me. This is a blank. We also recognize it from a report back from that legal assessment, like a legal professional being like, this is mine, I got it. However, we don't know if it's worth the squeeze. We don't know if it's worth the risk-benefit analysis of identifying that. We are working with lawyers means there's a lot of ethics conversations. Very, very grateful for the ethics conversations we have. The philosophy graduate me is always very happy about that. But just note we're sitting in that right now. We are comfortable with the legal needs concept and are exploring everything else. Next slide. Okay, next slide. We have a slash mark here that we will resolve, Susan. We would never submit something to SNOMED that has a slash mark. But we recognize a very, again, tangible goal of connection to legal advocacy being a good goal to work at. And we're access to or connected to, we haven't quite decided yet. We promise by the time we come back next in 2 weeks, we will have solidified whether it's access to or connected to. We've had a very lovely conversation about pros and cons of each one, and we will settle on something before when we come back. And there were some considerations of whether it was helpful to have kind of lofty goals, and our SMEs were like, for right now, like they wanted tangible goals, which is great, given the work that they do. Next slide. And Omar, anything to say here? I don't want to interrupt you. Are we good? I don't want to
Yes.
override you.
Yep, we're good.
Okay, sounds good. All right, next.
You both did a great job and really capture
Oh,
our
good.
discussions and the points made during the SME meeting. So thank you.
Great. I just want to do justice. Aha. No pun intended, but maybe pun intended. Okay. Any questions on legal needs? And then is our lovely friend Danielle here yet? Danielle Hessler? No, it's not. Okay. It's not. She's coming at 5. Yes, Sarah B. Next slide. I think we're in. Yeah, wow, Asha. It's amazing.
We
So
were
I'm gonna.
worried.
I was
Yeah.
worried. I'm going to waste time for a little bit and just try. We're waiting for our lovely guest from UCSF Siren, our co-founder, to come onto the call. She's going to be here at 5. So I'm just going to reiterate on some of the things that we saw, and some of the things we're going to be asking you to do. So next time when we come back, you can expect that instruments are not going to be on the slides because we've seen them multiple times. They will only be available in the master list and on the Confluence. Next time, we're going to be solidifying on our definition options between the multiple different types of definitions. And the moving of instruments off of the slide deck into the master will allow us to focus on what should be a blooming of goal and intervention concepts over the course of the next couple meetings. We promise to bring to the subject matter experts the considerations that you all raised, specifically within child maltreatment, ensuring that different types of experiences are contained in the definition happens a lot. I will note that we didn't include all the EGs in our definitions. If you look specifically into the CDC surveillance concepts or into the WHO concepts, they do a lot of as exampled by ... For the sake of clarity, we didn't include those, but we will test the phenomena that you all wanted to represent against those definitions before we come back with the SMEs. And then I think we have 2 more concept meetings before we go into end-to-end review, right, Asha? Okay. And again, I think let's focus again. Can we skip ahead past it's hard to skip past the the social experiences measure. Any questions before we move on from anybody on what we've covered today? Our next steps? No? Okay. And then can we just because I know the moment Danielle comes, we're gonna have a lot of conversation on that measure. Sarah B, can you sneakily take us to the concept we presented last time, the assessment of, or whoever is, the assessment of social care concept? Move us that one. Oh, look at that sneaky business, Asha. We have so this is a concept that we need to vet with you all for inclusion. For some reason, it's been kept off of our assessments and consensus work over the course of the last few sessions, and so we're bringing it forward. And now I'm going to not waste time, but talk about level setting, about why we have our friend coming. Okay. So our members have and our community has consistently over the course of the last 6 years asked us to develop standards to identify outcomes, right? And we've been thinking about, so much so that in 2024, members identified 2 priority new areas of work that they wanted us to focus on. And one was payment and reporting standards. And for that, we leaned into things like coding for food, trying to develop HCPCS concepts for food as medicine concepts, working with HL7 on standards for social care claim submission. And within we also had a secondary discovery on outcomes. And for that, we're curating all the different ways that we identify outcomes in gravity. Everything from change across two instruments, change in a condition after an intervention, like referral status, procedure status. There's a million and one different ways. One of the things that our subject matter expert, our members have always asked for, and I just got an email about this 2 weeks ago, which made me think about this, was about patients' experiences of social care, right? And they said, we don't have, because in clinical practice, we have things called CAPS measures that measure experience with clinical care, right? So after a patient encounter or a client encounter, a patient gets a survey, and you've all gotten them, right? That identifies how, like my perspective, the patient's perspective on the experience of care. Did the provider listen to you, right? Were you respected? Did they ask you about your medications? Did you get results in a timely fashion, right? So those are all clinically relevant experiences of care measures that are formalized and part of quality, like, quality delivery of services across the clinical ecosystem. Every single touch, you generate a sample of patients that are queried in this CAP survey. So our friends, and I'm just going to have to, I guess, I'm going to start with, because Danielle's supposed to join at 5. I think we're just going to have to start, and she can come and add more color if need be. So our friends at Siren worked over the course of years, and if you remember, UCSF Siren was one of our co-founders, to develop just this, a patient experience of social care measure, and we're bringing it to the community for consideration, and if approved, it would become part of we would encode it in LOINC and include it in part of our standard methodology within our value sets and questions and answers. And it's relevant to all social care, so it would not be in a specific domain. Next slide. And I'm going to start, and we'll just hope Danielle Hessler, whenever she comes, she's so lovely and smart, she can speak to it. So the team at Siren is always on the cutting edge. They were the cutting edge when they helped develop Gravity. Like in 2000, oh, she's here? Oh, Danielle! Fantastic! Just when I was trying to, like, my Lord, I wasted enough airspace, Danielle, to give you the floor, my friend. I did have time to call you cutting edge, though. My friends at Siren. Hi, Danielle.
Hi.
Hi,
How's it
buddy.
going?
I know, we're good. It is my
Good.
honor. I set you up. It's my honor to give you the floor while you talk about this patient experience of social care measure. And then thank you so much for coming.
Absolutely. Thanks all. And sorry to be zooming in. Happy to be here and get to join. So I just have a couple slides, and then I will welcome any and all questions. So the briefest of backgrounds on this is that, as I know this group is very, very well aware, there's been, of course, a big push and focus on some of the metrics around social risk or social needs, or if you want to call it health related social needs, any number of these headings around screening and referral activities. And so on the Siren team, we of course have been eagerly tracking these. And we've also been hearing over the last few years a growing concern that has been sometimes, if you will, a lopsided focus in the metrics and how we record things on the quantity of an activity that's occurring. So for instance, the number or percentage of individuals who are asked a set of screening questions, or the number or percentage of individuals who receive a referral, compared to assessing the quality of those services. And so what we set out to do was to create and validate a patient experience of social care measure to act you can think of it like a counterbalance. So it's not meant to replace all these awesome metrics that are out there focused on the quantity, but to counterbalance that with making sure that we're not resorting to a check mark box when it comes to social care, that we also have an eye to ensuring that patient experience and a high quality of care received. So on the next slide, this is kind of zooming forward to like, here we are a couple years later. There's a ton I could tell you if you want to know about the development and how individuals with lived experience were there at the table the whole way with us, the qualitative work that then led to a national survey that then led to a whole bunch of psychometric analysis. But that would be getting into the details. Really, what we have here is the end product of the items themselves. And so the idea behind this measure is that it's asking people to report on the last time that they were asked about their social or financial situation in a healthcare interaction. This wording can be altered to fit a specific circumstance if necessary. And then the items are broken down into 3 categories. So the first 4 that you see here are really focused on that experience of being asked the questions. So whether or not and they're all rated on, these are rated on a 1 to 4 scale. So whether or not they understood why they were being asked the questions, if it was clear and in their preferred language, if they felt they could trust the team with the information, and if they were asked in a way that was respectful and towards them and their culture. The next set of 2 items is about their experience of assistance. So this is referring to resources, information, or referrals that they received. This, in addition to the response ratings, has a not applicable. So it's for individuals that did not receive any information or referrals or resources, it's not applicable. But for those who did, whether or not to the extent to which the information they received were up to date and relevant, and the extent to which it helped them with their situation. And then the very last item you see pictured here is a single overall item that asks them, and this is actually on a 0 to 10 point scale, analogous to the CAPS validated measures, asking how they would rate the overall experience of sharing their social or financial situation in that interaction. So I am happy to be here to answer any questions. I know that's the very briefest of overviews of this measure.
Danielle, that's amazing. I'm so glad. So any questions? I hope, I mean, I was like champing at the bit the whole meeting to get to this, and I have to admit that that's probably not but because this is such a huge like step forward for concerns this community has raised to date. And the fact that we can once again bring our amazing friends at Siren back to present on this is such a lovely thing. Of course, anytime, Lucy, I know you have, okay, let's do it. Ask Danielle questions. I'm sure Lucy, I'm sure you see this as, I'm sure this is addressed as a Lucy problem if I ever heard one.
Thank you, Danielle. Under experience of assistance, in other settings, I have become aware of a tsunami of referrals for social interventions that result in agencies saying, we can't do this. We are overwhelmed. So under experience, is it possible for someone being surveyed about this to say, this is about access. When there's no access, you can't receive anything. And so maybe you were referred, but you were rejected because capacity was 100% and they couldn't admit another. I'm really grasping for trying to be the patient answering this kind of survey in a healthcare setting. I'm so happy you asked me this because I was referred here and they said they didn't have anybody to help me.
Mhm.
So is that relevant to experience of assistance?
Absolutely. We heard this, we have and continue to hear this a lot. And this is again a great example in my mind of the disconnect between we may be feeling on the one hand with our quantitative metrics, okay, I gave a referral, check mark, like done, right? And then the patient's experience is they're calling up or they're waiting for a call. They're told, no, we're at capacity. We're not accepting this.
Exactly.
Maybe try over here. There,
Mhm.
that results in lack of connection, frustration. And so for that individual, they, if it was me and what we were hearing from patients in our what we call cognitive interviews, where they had us walk through their lived experience and what ratings they
Mhm.
gave, that would be a low rating here on experience of assistance. Because it and because that's
Okay.
highlighting that disconnect of like, yeah, I was provided something. So yes, no, yes, I was provided something, but it didn't help me. It didn't ultimately land and
I
change my
got you.
situation.
Okay, so no is is an answer that I could give here for experience of assistance. And then there would be a box that would say, tell us what happened. And I would say, I could never reach them, or they were at capacity, or we talked and I didn't like them, or, whatever it's going to be.
Mm-hmm.
That's what
Oh,
CAPS does. When something goes wrong,
Mhm.
there's a
yeah.
narrative cell where you can say what happened. Okay, great. Thank you.
I love that idea too of the narrative of from a numbers perspective, with these items, it could tell the story of like, okay, here's what happened from the patient point of view. And again, it's like it's on a 4-point scale. So it could be everywhere from like, basically a not at all helping all the way up to like, yes, this was excellent. This is great and really helpful. We and we defer to a given implementer, whether that's a health system or otherwise, if they want to include something what you're describing, the qualitative free
Mhm.
response. Because for some users, they're not in a position to review or respond to those fill-in answers, and for others they are. But I think that's like a great use depending on who it is that's implementing it.
Well, if you could sell this to Press Ganey, then
Yes,
everybody would get it all the time.
yes,
That's Danielle's mission. I know.
Okay.
that is the mission.
I know. I think,
Thank
yeah. So I
you.
remember, I think it was like early conference, like 2 years ago, brainstorming about this. And I was like, I want it in caps, man. I want it to
Yes.
live right
Well,
now.
Okay.
it's interesting. We did meet with when we were forming this, we did meet with a couple of folks who are responsible for determining items for CAPS, and we asked their advice. And that was actually part of what drove the idea of the single overall item, because they
Mm,
gave us this feedback saying, I don't know, like very early on. They were like, we don't know about the idea of several items. They're like, if you could include something, some overall item that's analogous to our structure, and then of course we brought this back to individuals with lived experience. They're like, we would very much consider that. So,
okay.
we are very much hoping and pushing on that lever too.
Go, Danielle and Simon. Susan, do you have a question?
I
Hi,
do.
Susan. I know, I'm sure
Um,
you do.
I, well, I'm turning my camera on and on and off. Um, so if this has been validated, we're going to put this in Loink. Is that right, Sarah D?
Correct.
And if we want to add the additional questions, qualitative type questions, the whys, now's the time to determine that, because we can put those in too. It can just be a follow-on question that you have for your questions. We could put it on each one, actually. Um, so, and then I need some clarification from you. You said one thing that has me worried. And I want to make sure that that's not what you meant. You said that they can change the questions how they want.
Oh, so what I was saying is not that they can change the items how they want, but more this beginning instructions. For example, Kaiser Permanente is implementing this, and they were lightly editing this to be at a Kaiser healthcare interaction
Oh,
because
Okay.
they're
okay.
interested,
Yeah.
for instance, in like,
Yeah.
they're interested in their own internal, as opposed to,
Okay.
you went somewhere else and it wasn't Kaiser. So
Yeah,
sorry.
this is I was the director of nursing of a hospital, and this is a patient satisfaction survey. So
Yes.
it's
Yeah.
exactly what, right, yeah.
So
Yes.
that
And thank you.
healthcare
I'm glad you clarified that. Yes.
Yeah, so it's
Thank you.
that bolded healthcare interaction that is
Yes.
modifiable to like
Yes.
specific settings. Yeah. Okay, great. Any other questions? Oh my God, this is so exciting. I know for some people who are not as nerdy, maybe it doesn't seem as exciting, but it's very exciting to me because what I feel very powerfully is how this measure addresses concerns with widespread implementation without reflection, right?
Hmm.
And we would never be true to the mission we have at Gravity if we didn't ask those, did it work for you? We talked, when, Daniel, before you arrived, we were talking about all the ways we support outcomes measurement. Were you actually connected? Did the procedure actually happen? Did your
Hmm.
condition improve? Did your condition like remit? Did it change something, right? But this has been this missing area in outcomes that we haven't been able to measure until now. So yay.
I am so excited to come somewhere where you guys are excited because we are similarly very excited, and it was so exciting to work with a number of individuals to have them tell us at multiple junctures along the way what content do they feel like is important that drove
Mhm,
their experience.
mhm,
And they did that in a number of ways, through qualitative interviews, through like ranking scenarios, through
mhm.
telling us when language was confusing, when they wanted different language. So just in case that background is helpful too, sometimes we get really excited and we think we know what's most important. And I bet that all of us are looking at these items going, oh, there's other things we could have asked. And you're absolutely right. There are always other items and other concepts we could have asked about. But our North Star here was going back to the individuals that are experiencing social care and asking
Great.
them. And this is what really came to the top.
Love it. Thank you so much for coming.
Thank,
And so,
thank you.
yay. So community, this will now, this is one of our cross-domain enhancements. So we'll be, you know, probably recycling this next meeting and just reminding everybody, and then it will be, of course, part of our consensus vote in May to see if we can include it, and then we would work on developing it in like. And I just love also just UCSF Siren, our co-founding friends, back to the Gravity Forum for this. So glad. Thank you
Thank
for
you.
coming,
Thank you so
Danielle.
much for having me. It's so nice to be here with you all. And you just let us know, anything that comes up and anything that we can do to support the awesome work that you're doing.
I just love that I wrote Laura and Danielle and you all. I was like, can we? And Laura was like, yes.
Yes, please.
Yes,
Sarah,
please.
Sarah,
Yeah.
Sarah, I just had one more thought for Danielle. Up at the top, such as housing, food, transportation, these are, from a personal point of view, very neutral things that might be giving me trouble, but that I'm glad that I was asked about. What about the whole violence and maltreatment realm?
Mm,
Could that
Mm.
be in this parentheses?
You know what? That is such a good question because, as you know, depending on the context, sometimes violence is included with social risks and or social needs. Um,
Well, we've certainly
Questions, and
considered
sometimes
it
it's
as
yeah,
domains
yeah.
again and
So
again.
yeah, so I would say that that is absolutely something that that could be added there in the parentheses to fit the context, right? Like if that is aligned. And the only thing that I'm thinking about is if it was at the same interaction. So you know how sometimes the screeners do combine those, and then other times the violence screening is at a different healthcare interaction. Do you any thoughts from the group on that?
I think our Futures About Violence SMEs would want us to focus specifically on, like, separately on it as opposed to include it. And they would want us to have specific, because the sensitivity and privacy, I mean, Lucy, even in our approaches, we treat, I mean, I will let Lisa James speak for herself, but even in implementations, when instruments combine them, we recommend that individuals think about it differently, right? Like the HCHRSN, for example. We're always like, this is one, like, we're like, those last bits, they're different and should be handled differently. Anyway, it's a food for Lucy's always full
Well,
of
that's
thought.
fine. It doesn't have to be here.
Correct. It needs to be somewhere,
But
though.
this is a
Yes.
template. This is a
Yeah,
template now for other
exactly.
things that
Yeah.
could go in those parentheses.
Yes.
Thank you. Okay.
Yeah, because I think about specific questions that, like, an IPV survivor might have about, like, did I feel safe? Like, there's just unique, and Danielle, there's your next
There we
research
go.
project, and, like, there you go.
Absolutely.
2 years, we'll see you back here.
Your next grant.
I know. And then
Yeah.
Lisa's all set up, and you'll do the Q's model. Like, was the Q's model performed prior to my IPV screening?
Well,
Exactly.
and it's nice that they are so general because the location gives you context and you can use them, for different areas in a different context.
Exactly.
Go team. Anyway, thank you so much, Danielle. We appreciate
Thank you so
More to come
much.
in May.
Yes,
And,
yes, we would love to be back.
We love that.
Bye.
All right. Bye. All right. I think that's okay. If we go to the homework and next steps, I think we're ready. I did kind of the homework as a bridge to letting Danielle arrive, but the biggest job is to start looking at master lists and making sure that they represent things, to review all of the intervention concepts that we have in the works. And then we're going to, Sarah's like, please submit concepts. And then the SME groups and us, the team, will be deciding on definitions and adding goals and interventions over the course of the next couple weeks. We thank you all for coming. Anything else, friends, that we need to say before we go? I hope you're as excited about the patient experience of social care measure as I am. Have a lovely evening, and we'll see you back in a couple weeks. Bye.
Thank
Bye.
you.
Thank you.
Thank you. Good night.